importante acá es que estos pacientes estudiados con IBP con pH impedancia sí tenían un aumento en la exposición al ácido o en criterios más estrictos, un aumento a la exposición al ácido más de 4, más de 80 episodios de reflujo o una impedancia basal baja. A estos pacientes sabemos que les va a ir muy bien con una intervención quirúrgica. De nuevo, muy cuidadosamente escogidos, pero estos son parámetros que se pueden utilizar clínicamente. Y por eso el consenso de reflujo latinoamericano y también el consenso de Lyon dictan que la pH impedancia es el método diagnóstico de elección para estudiar un paciente con reflujo ya confirmado. Sabemos que tiene reflujo, pero con síntomas que persisten a pesar de la supresión ácida. Lo de los eructos supragástricos se mencionó también ya más temprano brevemente. La impedancia de nuevo puede detectar también movimiento de aire. Cuando hay aire presente alrededor del electrodo de impedancia, la señal sube. Entonces acá pueden ver, este es un eructo gástrico, subidas de impedancia que empiezan en el esófago distal. Hay aire acá y esto se mueve de manera retrógrada y sale por la boca. En contraste, durante un eructo supragástrico, donde todo ocurre por encima del diafragma, el paciente ingiere y succiona aire. El aire entra proximalmente, llega hasta el esófago distal y sale de inmediato. Y esto se puede determinar claramente con pH impedancia y es algo que responde a intervenciones como terapia de la conducta. Y ya por último, bueno, y obviamente por esto, tanto el consenso latinoamericano como Lyon II sugieren que la pH impedancia es el test de elección para estudiar a alguien que tiene eructos muy frecuentes. Ya por último, la impedancia basal, brevemente sabemos que cuando no está sucediendo nada, no está subiendo aire, no está bajando líquido, no hay reflujo, cuando está en reposo y la sonda está tocando el epitelio esofágico, los pacientes con reflujo tienen una impedancia basal baja comparado a controles sanos. Entonces es una medida que puede utilizarse como una medida de apoyo diagnóstico cuando hay poca certeza, pero generalmente apoyándose también en otros criterios. Entonces, ¿cuál es la utilidad del moteo o cuándo podemos utilizar pH con impedancia? Bueno, podemos utilizarla para confirmar o descartar reflujo. Sin embargo, yo en este ámbito, si no tengo seguridad de reflujo, en casi todos esos pacientes lo que hago es una pH-metría inalámbrica. Primero responder la pregunta si tienen reflujo, sí o no. La pH impedancia la reservo más para pacientes con ERGE confirmado, pero que tienen síntomas refractarios, porque eso me clarifica el mecanismo. A lo mejor el IBP no le está funcionando y continúa refluyendo ácido. A lo mejor el medicamento está haciendo lo que se le ha pedido, suprimir el ácido, pero el paciente refluye material no ácido y esto está causando los síntomas. O a lo mejor el estudio de pH impedancia muestra que no hay anormalidad de reflujo, el paciente lo que tiene es reflujo controlado. Acuérdense que tenía el reflujo ya comprobado, pero también tiene un componente funcional de hipersensibilidad y previgilancia. Entonces, muy útil hacer el estudio paciente con reflujo confirmado, pero que no responde, hacerlo con pH impedancia. También en eructos supragástricos, y cuando el diagnóstico de reflujo no es incierto, pues uno puede apoyarse en estos parámetros adicionales para tratar de ver si la balanza cae a favor o en contra del diagnóstico, utilizando impedancia basal o el número de episodios de reflujo medidos por la impedancia. Muchas gracias.
Muchas gracias, Marcelo, excelente ponencia. Y ahora quiero invitar a nuestro siguiente ponente, al doctor John Pandolfino. Muchos conocido, John ha sido ya asiduamente invitado y ha aceptado generosamente acudir a nuestros cursos. Bueno, no tiene necesidad de mucha presentación, es un líder de opinión en trastornos motores, ha investigado mucho alrededor de la manometría esofágica y ahora tiene desde hace ya años desarrollando investigación en el EndoFlip. Dice New Kid on the Block, not that new, pero en México es que tenemos inicialmente esta tecnología y queremos que John nos encamine. Él está en Northwestern, en Chicago, y bueno, es el jefe de la división de gastroenterología. Adelante, John.
Well, thank you very much. It's really a pleasure to be here. The talk that I'm going to do today, EndoFlip, New Kid on the Block, is going to primarily focus on the differences between FLIP and high-resolution manometry, and also discuss how they're complementary and not competitive. Okay, so that's going to be the main thing here. These are my disclosures, and these are obviously important to understand because I do have a patent and share the IP with Medtronic for a FLIP manometry. So in terms of thinking about this as the new kid on the block, it's actually been around for quite a while. And it was interesting, I saw Ronnie last week, and we were discussing FLIP at this conference, and I reminded him that he actually visited me when I was a fellow, and he was a junior faculty at that time, and I was working on the barostat, which was a mechanism to assess sphincter distensibility, and I was having a lot of trouble keeping it in the sphincter because the bag wanted to move. You know, when you're doing a dilation, the esophagus wants to push the bag into the stomach. So I created something called the hydrostat, where I put some renographin in there, and we actually could see it on fluoroscopy and get these really nice images and measure compliance, but it was very troublesome in terms of needing fluoroscopy, timing it, making the bags. And then two investigators, Hans Gregerson and Barry McMahon, came up with the functional lumen imaging probe, and we're working with a company called Crossbond. I happen to have the patent for distensibility testing in the esophagus, and we decided to work together on assessing the mechanical properties of the lumen. And really, this was a very simple cartoon, but it just kind of shows you what happens when you blow up a balloon in the esophagus. Sometimes it just sits there. Sometimes there are contractions and wants to push it into the stomach, and that's kind of normal. So you can feel that tug. You can feel that when you're doing an esophageal dilation. You can see the balloon moving into the stomach. And we realize that that's a mechanical response, probably a secondary response to distension. And it was interesting because we were looking at eosinophilic esophagitis, and we were trying to assess the biomechanical properties of the wall and how stiff the wall was in eosinophilic esophagitis. And when we were doing this, we were actually doing high-resolution impedance planimetry. So Satish Rao did studies where he looked at impedance planimetry at a focal point, but we were actually looking at high-resolution impedance planimetry. And we noticed these signals in the impedance planimetry that did look like they were actually contractions. So we took a page out of Ray Klaus and we turned it into color topography. And then what we could see were these beautiful peristaltic sequences that were propagating down the esophagus. And there's a pressure sensor in that bag, so we could see that that correlated with that rise in pressure. So really what we figured out was that we were actually assessing secondary peristalsis. So manometry, as you saw in the first presentation, is typically done with wet swallows, water swallows. That's primary peristalsis. It's typically vagally mediated, and once it hits into the smooth muscle, it is certainly helped with smooth muscle function, and then the intrinsic enteric nervous system. What happens with secondary peristalsis is when you're distending the esophagus, depending on where it is, if you're in the striated muscle portion, it sends a centrally mediated vagal response that causes a contraction and peristalsis. But if it's a little bit lower, you're actually causing an intrinsic distension and an intrinsic response that tries to move that balloon out of the esophagus and into the stomach. So that's really the difference. One requires swallowing, and one does not require swallowing. Well, the nice thing about FLIP is that it's actually done during endoscopy when the patient is sleeping. So as you heard Ronnie talk about the catheter being uncomfortable, and you saw the issues that there were placing the manometric catheter, none of these problems exist with FLIP because you're placing it while the patient is nice and comfortable, and sometimes even during that index endoscopy. So this is what FLIP looks like real time in a normal control. So an asymptomatic control patient, you see this beautiful contraction where you see these, I have bad aim it looks like. You can see these beautiful repetitive antegrade contractions propagating down the esophagus. Now FLIP is a little bit unusual because if you blow a balloon up in the esophagus, typically the lower esophageal sphincter relaxes and so does the distal esophagus. But because there's distension through the entire esophagus, it elicits this very unique contractile pattern. We also saw that there were some patients who we blew the balloon up in and nothing happened. And then there were these patients where we blew the balloon up, the sphincter didn't open. You can see the sphincter really tight here. Right there, very tight. And you could see these chaotic contractions in the esophageal body. In fact, one of my friends who's a cardiologist looked at this and he said that's fibrillation of the esophagus, which it actually probably is. So it's very interesting that we could see these distinct patterns. So as we were exploring these contractions and these patterns, we started to think about whether or not we could put this into a classification scheme. But it was very interesting because I think before we did this, we really wanted to get to the physiology of what was going on here. And it was interesting. There were some people who just thought this was artifact, which was completely ridiculous, but we had to address that. And this is an example of a study that we did where we actually had the same patient, that's their high-resolution manometry, unsedated, showing beautiful primary normal peristalsis. In that same patient, we actually placed a flip balloon alongside the manometry catheter, and then while the patient was sedated, we blew the balloon up, and you could actually see the rack pattern on the manometric catheter. So the bottom panel is manometry. Both panels are manometry, they're not flip. It's just showing that this was the normal manometric pattern that you would see when you would blow a flip balloon up next to a high-resolution manometry catheter, clearly showing that this was not artifact. So then we did another experiment where we put a proximal balloon above the flip to show that these particular patterns were responsive to a descending inhibition where they would just relax. So you blow the balloon up in the proximal esophagus, the esophagus should relax, and the LES should relax. And that's what we saw here. You can clearly see that when we filled the balloon, the rack pattern went away. And actually, even though it looks like there's a little bit of resistance there in terms of diameter, the pressures went down significantly, and there was an increase in distensibility. And you can clearly see the racks come back when we empty the balloon. So clearly, this is a peristaltic sequence. And we also showed that it was atropine sensitive, because if you give atropine, you obliterate the rack pattern and the antegrade contractions. And we also showed that it was constrained by the same things that were constraining peristalsis, descending inhibition from a proximal balloon distension. So this is a real physiologic response. So with that, we also started looking at the rate of these contractions. It was very interesting that in normal people, when they have these contractions, they tend to occur 6 times per minute. But when we looked at patients who had documented achalasia, especially achalasia 2 and 3, they would have 12 contractions per minute, plus or minus 3. And really what you're showing here is that this defies the refractory period and the descending inhibition of the esophagus when you lose it, right? So in patients who have spasm, they have no latency gradient, so they can actually fire very quickly, almost every 5 seconds. Whereas we know from early studies from Don Castell, the esophagus kind of takes in a normal person about 10 seconds to reset to have a normal peristaltic sequence. So once again, getting back to this whole physiology of peristalsis. So what do we do with this device? So early on, our main assessment was really at the esophagogastric junction. And we'd looked at this along with our colleagues at the AMC in the Netherlands, and really showed that this was a really nice tool to show whether or not the esophagogastric junction was opening. Now, the LES can relax, it can partially relax, but the most important component, as you heard from the first talk, was whether or not there's obstruction at the esophagogastric junction. And really, this is a wonderful tool to look at the opening dynamics of the esophagus. So this is an example of these 3 images of an untreated achalasia patient, and then a patient who had a good response with maybe a Heller myotomy or POEM or a pneumatic dilation, and then a patient who had a poor response. You can see that really, really tight waist there. So you can see right there, this is a patient with a poor response, looks very similar to the untreated, and then you can clearly see the person in the middle has a really nice response. So the esophagogastric junction is opening with low distensile pressure, right? So that's what you want to see after an intervention at the esophagogastric junction. So when we started looking at this, we started to note that once again, we could actually come up with measures that were very similar to manometry. So manometry is on top. So these are all manometry images. So these are normal peristaltic sequences. And this is the same patient. And you can clearly see these antegrade contractions and the esophagogastric junction opening with those pressure peaks. Similarly, in the achalasia patient you see here with aperistalsis and an IRP of 46 and 55, you can see a very tight EGJ and very minimal peristaltic activity in the body. Classic for absent contractility with an EGJ that's not opening. So as we extrapolate with that, we wanted to make sure we didn't make the same mistake we made with the IRP. We wanted to define, we wanted to define areas where we were very confident that there was an obstruction and areas where we were very confident that there wasn't an obstruction, and leaving a zone of inconclusivity, where these were patients that you may need to get another test. So we didn't want to make a line in the sand where this was normal and abnormal. We wanted to give a little gray area because the technology in and of itself is never perfect, right? We know that an IRP saying 15 is plus or minus 1 is abnormal or normal is kind of crazy because the catheter is not that sensitive. It misses things. So the other thing that we saw that was very interesting was that we saw that there were patients who had normal manometries on Chicago classification, but their flips were very abnormal. So we went back and looked at these patients and we said, well, if we would have done an endoscopy and done a manometer on these people, they would have been considered functional dysphagia, right? Well, if you did the flip, you would see these very distinct or very spastic reactive contractions at the sphincter. And one of the things that we saw was that this was typically seen sometimes in these patients with hernia, and a hernia that wasn't appreciated on manometry, but actually appreciated on flip. And when they would get these fluoroscopic studies where the radiologist would press on the belly, you can clearly see these areas where, did I lose it here? Oh, maybe it has to reset. Well, in this, you can clearly see B and A Schatzky's ring and a contractile A ring. These two other examples were very interesting because even though they had very abnormal flips, they had pretty normal looking manometries, normal relaxation, normal peristalsis, but when you looked at their esophagograms, they were grossly abnormal. Two of these patients even had diverticulum, which suggests that there's difficulty getting the bolus out of the esophagus. So we believe we've probably uncovered a distinct entity that has dysphagia related to improper motility that is elicited by a distension, not just a primary peristalsis. So these are patients who may get food impactions, may have a discoordination of the musculature, and may develop diverticulum. So this is a disorder that if you catch this and they have an abnormal esophagram, we typically give Botox to the LES before we do anything, just like you saw in the first presentation. Now, we move this now into assessing peristaltic patterns, and you can clearly see in these examples here that these patients actually have a progression of normal. Maybe they may not have the rack pattern, but they have beautiful antegrade contractions. Then these patients have some sporadic disordered. And then this patient over here, I think the battery might be dying. Patient over here has scleroderma esophagus, if I can get this to work. Well, that fourth panel, second one from the top on the right, actually is scleroderma esophagus. And then there are those spastic disorders. And it was interesting because when we were looking at scleroderma patients, the scleroderma patients have manometries on the top and flips on the bottom. We saw that there was heterogeneity in those three patients who are on the right who actually have scleroderma esophagus, absent peristalsis and hypotensive LES. If you look at them, the first person in the middle panel has beautiful normal racks, and the person at the end has complete absent contractility. So that person has a defect in primary and secondary peristalsis. And those are the patients that we found had the most severe complications of reflux esophagitis and even the most severe pulmonary disease. So we believe that the tipping point for scleroderma esophagus may be loss of secondary peristalsis, even though they've already had primary peristalsis. And I think we've seen those patients, those scleroderma patients who are doing fine, who have absent contractility. Okay, so now we understand the physiology, we understand the patterns of this physiology. Similar to Chicago classification, just like you saw in that first presentation, we have a specific protocol where we actually place the balloon, we get a good baseline positioning, and then we subsequently inflate the balloon or fill the balloon to 50 mLs, 60 mLs, and 70 mLs, and look to see what the response is at the esophagogastric junction and in the body of the esophagus. And based on that, looking at EGJ opening and the pattern of contraction, we can come up with something called the Dallas classification. I'm not going to go into too much detail on that because my talk tomorrow is going to focus specifically on the Dallas classification. But now we have this opportunity to actually do this procedure while the patient is sleeping, before they've had any other diagnostic tests, do a simple distension protocol that takes 5 to 7 minutes, assess their esophagogastric junction, assess their body peristalsis, and give them a diagnosis. And that way we can maybe avoid high-resolution manometry in a good proportion of these patients. So this is what it looks like. You see the Chicago classification on the top. So here are the manometries: normal, type 1 achalasia, type 2 achalasia, type 3 achalasia, jackhammer, scleroderma, and GERD. And then right on the bottom are those same patients, the same flip. You can see those correlates in terms of the patterns, the similarities, the repetitive antegrade contractions when there's normal peristalsis, the absent contractility, maybe some of these spastic contractions. If you look at the patient with jackhammer esophagus, look at that kind of weird contraction and then the weird contraction you see on flip. So you clearly see these similarities and you can make these diagnoses. And that leads us to the end of this particular talk, focused on how do we apply this now. And I'm going to, like I said, speak a little bit more to that tomorrow. But essentially what I do now, I see a patient with esophageal symptoms, dysphagia, regurgitation, chest pain, maybe food impactions. We may rule out cardiac causes. And then I'll certainly send that person for endoscopy, because those are warning signs. I mean, someone has dysphagia or dynaphagia. If someone has regurgitation and not responding to PPI, I'm going to get an endoscopy, right? All roads lead to endoscopy. So I'll do the endoscopy, and if they have eosinophilic esophagitis, I'll dilate them if it's obstructive. I'll do biopsies. If they have horrible esophagitis, I'll treat that with proton pump inhibitor or PCAB. If they have a stricture, I'll dilate it. But we know 50% of those people are going to have a normal endoscopy. So right then and there, during that index endoscopy, I can place the flip, I can get a flip pattern, and based on that, make a decision. So if their manometry looks normal, or their flip looks normal, I'll probably do a wireless capsule to assess them for reflux. If it looks hypotensive with a wide open EGJ, I'll probably also do a wireless capsule in that patient. I won't get a manometry right away. If they have a pattern that looks like achalasia, they have a dilated esophagus filled with liquid and food, and I do a flip and it looks like achalasia on flip, they have a non-spastic obstruction, I don't have to put that person through a manometry. In fact, we found out in the first talk that doing a manometry in those people can be difficult. Curling catheters, uncomfortable, so I'll just do that right then and there. And then if I find people who have kind of spastic patterns or patterns that don't make sense or do not correlate with what I see on the endoscopy, those are the patients that I would get manometry on. So it doesn't replace manometry, it relegates manometry to patients who are going to have a higher yield of finding something abnormal. Whereas the people who are going to be normal don't have to get a manometry, and we can rule them out for reflux and rule them out for functional disorders. And the patients who obviously have achalasia, we don't have to torture them with another manometry. So I hope that this discussion on physiology, this new kid on the block, has brought you to a little better understanding and acceptance of where FLIP may fit in the diagnostic paradigm, which we'll discuss tomorrow. Thank you very much.
Muchas gracias, doctor, por su excelente ponencia. Y para continuar tenemos al doctor Ali Razi. Él nos acompaña, él es médico del programa de motilidad gastrointestinal en Cedar Sinai en Los Ángeles. Es profesor asociado también de la UCLA y director de bioinformática y biotecnología. Y él nos va a dar la plática de pruebas de aliento, lo que debemos saber. Adelante, doctor. Y, perdón, adelante hay lugares por si quieren pasar a sentarse.
Thank you so much. So let's get started. Alright, so these are my disclosures. So just quickly, what objectives I'm going to cover. I'm going to talk about practical approach to breath testing, specifically to microbial overgrowth syndrome. I'm giving a talk tomorrow regarding how to use breath testing tomorrow for carbohydrate malabsorption, so I'm not going to cover that today. Yesterday, Dr. Pimentel covered the translational research regarding breath testing, so I mostly focus on the practical approach for breath testing, namely how to assess the pre-test probability on symptoms and causes, and based on that decide which test to use, for example, with lactulose breath test being more sensitive, less specific, and glucose breath testing being more specific, less sensitive. And also the limitations of the other tests that also will guide you what to do with breath tests, and also the cutoffs. Just to summarize the microbial overgrowth syndrome, so we know that the small bowel is relatively sterile as compared to the colon, with 1 million-fold less bacteria in the small bowel as compared to the colon. And it does that mainly due to migrating motor complexes, the housekeeper waves, that keeps the small bowel relatively sterile, but continuously pushing the bacteria and also fungi, and also the viral particles that we are understanding into the colon. The subcategories, general subcategories, are small intestinal bacterial overgrowth with more than 10 to the 3 colony-forming units, and these are coliform bacteria mostly. These are Klebsiella, these are E. coli, and also when you have more than 1,000 colony-forming units of fungi, mostly Candida glabrata, and also Candida albicans, which, by the way, Candida glabrata changed its names, but those are the main fungal overgrowth particles that we see. And also intestinal methanogen overgrowth. The intestinal methanogen overgrowth can happen in the small bowel and the colon. It's caused by archaea, the methanogenic archaea, and these can't be cultured. So the only way to diagnose this is through breath testing. Now, just a quick point. Remember, the microbial overgrowth syndromes, yes, the gas production is abnormal and fermentation is abnormal, and that's one of the sources of symptoms, but there are many other sources of symptoms because of these overgrown bacteria, because of the side products that they produce. Let's say histamine that causes abdominal pain, serotonin that can cause diarrhea, and they produce all other sorts of side products. And also the intestinal microinflammation and abnormal intestinal permeability that happens with these also is a factor. So before I get to it, so when you set up the test and also you're talking to the patient, you start to get a sense, okay, is this a microbial overgrowth patient or not? In my mind, the cardinal symptoms are postprandial abdominal bloating and distension, right? So those are the things that patient says that, hey, I'm eating, and as I eat now half an hour or a few hours afterwards, I start to get more and more bloated, and as the day goes along, I'm getting more bloated and distended. And usually I wake up in the morning flat and I'm feeling good, or if I fast, I feel good. So when I hear that story, obviously that increases my pretest probability that this is a patient with microbial overgrowth. If the patient has no bloating, then my pretest probability definitely decreases. So early satiety, nausea is another a symptom that they get, but it's not as common, and it's usually also a postprandial. Abdominal discomfort usually comes with bloating. If patient has abdominal pain, irrespective of bloating, again, I look for other causes as well. Now, they can get diarrhea and urgency. That's associated usually with hydrogen predominant bacterial growth or hydrogen sulfide predominant bacterial overgrowth. And also they can have constipation that can be associated with intestinal methanogenic overgrowth. But these are not universal rules. So you can see a patient with diarrhea and EMO, and vice versa. You can see a patient with constipation with SIBO. So keep that in mind. And again, brain fog can occur as well, and malabsorption in severe cases. Also causes, right? So this also determines your pretest probability. Microbial overgrowth syndromes are not a primary disease. Usually they happen in the setting of something that triggered off this motility. And now that can be post-surgical, that can very commonly, for example, with adhesions. Now adhesions can be after surgery, or it can be actually in somebody with virgin abdomen with somebody such as endometriosis or missed appendicitis, that we see adhesions in the abdomen even without prior history of surgery. Again, small bowel dysmotility, very common. Scleroderma has an odds ratio of 10 to 11 to have small intestinal bacterial overgrowth. And also medications, narcotics, anticholinergics, GLP-1 agonists now are very common causes of stasis of the gut and bacterial overgrowth. PPIs, generally we consider them to be benign. In fact, Jose Maria has a great study on healthy subjects that the rate of development of bacterial overgrowth, even in healthy individuals, is relatively low. So as long as you have normal migrating motor complexes, PPIs should not cause significant microbial overgrowth, mostly because they do not affect the small bowel gut microbiome as much, and the acidity of the small bowel. Now, there are ICD codes for all microbial overgrowth syndromes starting 2 years ago, developed by WHO and CDC. And I just summarize how we diagnose these. So keep in mind that SIFO cannot be diagnosed with breath testing, and you need small bowel aspiration. And on the other hand, EMO, the only way, at least in clinical practice, is in using breath testing. Deep sequencing of small bowel contents, still in research, but just like the stool tests are coming with deep sequencing, this will eventually make it to the clinical practice, but we're not there yet. And the stool tests are not they don't have any value in diagnosis of SIBO at this point. So I'm saying that because there's a lot of stool tests that claim that they can diagnose SIBO, but that is not true. So just a quick touch on small bowel aspiration. So remember, when we do the aspiration of the small bowel, usually we go into the deep duodenum or proximal jejunum, and we aspirate the small bowel from a 5 to 10 centimeter segment of the small bowel. Now, the advantage of this is that obviously you can identify what's growing, right? And also you can do antibiotic sensitivity. This also can diagnose SIFO, but on the other hand, one issue is that it has false positivity rate with the single lumen techniques. I mean, very elaborate techniques have been described, mainly by Dr. Rao, and that aspiration can be done very well. But I mean, with the single lumen, you are running a 20% chance of contamination, and that's the data from Dr. Lacey at Mayo, Florida. And also there's a false negative rate, right? It's about 19%, and that's because you're aspirating a 5-inch or 10 centimeter segment of the small bowel, and small bowel is 6 meters, right? So there is a sampling error going on there. And also we can't culture all bacteria. So now the good news is that the FDA has now approved dual lumen catheters for aspiration of the small bowel. And this hopefully at least decreases the chance of contamination from the small bowels. So the idea is that you go into the small bowel, and when you're in the small bowel, then the inner catheter enters the small bowel and you start aspirating the small bowel to decrease the chance of contamination. And when you do it this way, you will get good results with aspiration, because otherwise the old school way of aspirating in like 70s, 80s, and 90s has a lot of issues, right? But now we're seeing very elaborate testing with deep sequencing that you see all the abnormalities in the small bowel of microbial overgrowth patients with very specific bacteria, for example, E. coli, Klebsiella aerogenes, and Klebsiella pneumoniae being as disruptors. Now, going to the breath test, remember right now you have eaten your breakfast, so there's some carbohydrates in it, and the bacteria in the small bowel and also your colon are actively breaking down those carbohydrates and producing carbon dioxide and hydrogen. Now, on the other end, the hydrogen is used by other bacteria and also archaea to produce methane, acetone, hydrogen sulfide, and nitrates, right? So that's very important because the production of methane in our body is dependent on production of hydrogen by other bacteria, and that's a syntrophic association, right? So another important thing is that hydrogen and methane are only produced in our body by the bacteria and not by our cells. So these are exclusive biomarkers. So any hydrogen and methane that I find in my breath is produced by my gut microbiome. So that makes it a very intriguing option for testing. So principles of breath testing, so it becomes the fact that small bowel bacteria break down the food, and that leads to production of multiple gases. This goes to the bloodstream and we breathe it out, right? We also measure the amount of carbon dioxide in breath to adjust for the depth of breath that patients make, because each breath sample that they give doesn't have necessarily the same amount of alveolar gas. So we adjust for the alveolar gas. So that's why we can measure the hydrogen and methane levels throughout the test and estimating what was the hydrogen and methane levels in the alveoli. Now, what are the pros of the lactulose and glucose breath testing? So as compared to aspiration, theoretically, it assesses a longer segment of the small bowel. It's non-invasive, and methane and hydrogen are exclusive biomarkers, and it tailors the antibiotic therapy. So you can see based on hydrogen or methane, and also hydrogen sulfide, what antibiotic to use. And also it predicts response to antibiotic therapy. Such data actually does not exist necessarily for small bowel aspiration, mostly because you can do a bigger study with breath testing. But what are the cons? I mean, not every bacteria, not every microorganism ferments, so we're going to miss non-fermenting microorganisms. And the second thing is the false positivity that can happen with the sugar ending up in the colon, and you pick up normal fermentation of the colon by breath test, so it becomes a false positive. So a lot has been done to see what is the false positivity rate using the small bowel transit with scintigraphy, but there are essentially three cardinal issues and assumptions that makes the interpretation of those studies a little bit hard. Number one is that there is always a time lag between bacterial exposure and also detection of hydrogen. So it takes roughly actually 40 minutes for bacteria to be exposed to the sugar and production of the gas to a level that is detectable in your breath. So you can't adjust for that number in our gut because each bacteria is different. Another issue is that we see it on endoscopy all the time, right? Permeability of small bowel to gas is very different to permeability of the colon to gas. When we insufflate gas in the colon, it stays. That's why we have flatulence. But in the small bowel, it just dissipates right away, right? So that's an issue of variability in dissipation of gas in small bowel and the colon is very hard to adjust in scintigraphy study. And also the continuum of the small bowel movement. When you give something, obviously it doesn't go through as a ball, it goes as a continuum. And that is fermenting by the time that some of it reaches the colon. So it's hard to assess those. But nevertheless, if you look at the healthy subjects that has undergone breath testing, the specificity, so there is a 15% false positivity rate that is there. Interesting enough, in centers that do high volume and they do a good job in telling the patient what not to take the day before to do fasting, the specificity is higher. But overall, the message is that glucose breath testing is more specific, but less sensitive than lactulose. Another interesting question is that these healthy controls with positive breath tests, are these false positive or truly patients with dysbiosis that have no symptoms, which is quite possible, because we know that this asymptomatic dysbiosis exists, for example, in the setting of H. pylori or C. diff carriers. So Jessica Legrady actually did an interesting study. So patients who got a fecal transplantation with somebody with positive lactulose breath test had higher chance of getting IBS after FMT, even though the C. diff was gone, which is actually an interesting concept, even though all these donors were asymptomatic. This study just came out literally a week ago, which is actually interesting. It came from Austria. So they had 24 biofilm positive in terminal ileum, 24 subjects, and they did glucose and lactulose breath testing on it. And glucose breath test picked only 1 out of 24, while lactulose breath test picked 23 out of 24. So not surprisingly, glucose breath test may miss some distal bacterial overgrowth. So my final message on that would be essentially choose your test based on your pre-test probability. You have somebody with scleroderma, with postprandial bloating, obviously your pre-test probability is high, right? So you want a sensitive test, a lactulose breath test. But you have somebody with abdominal pain, no bloating, and you're not thinking exactly this is bacterial overgrowth. If you want to test for it, then you want to use a low sensitivity test, but more specific tests such as glucose breath test. So there are multiple guidelines that you can refer to how to target this. And this is North American consensus, which included Dr. Schmulson and also Dr. Valdivinas, that provides standardized protocol for breath testing. So this is how a normal breath test essentially looks like. So at baseline, we do hydrogen and methane, and every 15 minutes we assess this. Technically, you don't need to do it for 180 minutes, 120 minutes is fine. But if you continue it, you'll see a normal colonic rise in hydrogen, which happens after 90 minutes. Now, if the rise is more than 20 parts per million, that's considered positive within 90 minutes. And for hydrogen, there's a paper by Dr. Che that suggests that we should use a cutoff of 12 parts per million. And that's what we use at Cedars, 20 for lactulose and 12 for glucose breath testing. For intestinal methanogen overgrowth, it's a little bit different. At any point, if it's more than 10 parts per million, that's positive. And that's because of the nature of methanogens. They continue to produce methane even in the state of fasting. And that's why it's considered positive at any point, right? And this 20-minute cutoff correlates with small bowel aspiration and also deep sequencing. And also the 10 parts per million is valid for both glucose and lactulose and correlates with symptoms. It actually correlates with fecal load of Methanograevibacter smithii, which is the main methane-producing bug in humans. And also, if, for example, you do daily breath tests, you can see it how nicely it goes down. Now, how do we navigate it in clinical practice? So the data for SIBO is that you use, if you have, for example, hydrogen breath test, you can use rifaximin, ciprofloxacin. I use doxycycline in my clinical practice. And also, you can also use metronidazole. But if you have excessive amount of methane, then you need to suppress the methanogens as well, which are generally resistant to regular antibiotics that we use. So the common antibiotic that we use is rifaximin neomycin or rifaximin metronidazole that we use in clinical practice. Now, also elemental diets are helpful in this field, and they have shown that they decrease the symptoms and also improve the breath test. And one interesting thing is that if you look at the solid red line, if you give elemental diet, you can see that it from a small bowel fermentation pattern switches to a normal colonic fermentation pattern, which is the red dashed line underneath. So the rise essentially gets pushed forward towards the colon. That's what we want to see. So this kind of summarizes how breath testing can help you in clinical practice. In fact, this is one of the few areas in midgut functional disorders that we can do individualized testing and also individualized treatment for patients. So if you have microbial overgrowth, if it's hydrogen sulfide and hydrogen predominant bacterial overgrowth, oh, by the way, I did not cover hydrogen sulfide much because that's an area that is not commonly available. But hydrogen predominant bacterial overgrowth, we treat it with usually 14 days of antibiotics. But on the excessive methane production, that's the time that we use neomycin and rifaximin. Now, if patient has clinical response, you educate the patient about clinical recurrence because it has 50% chance of recurrence within 1 year. And also you can adopt a strategy for maintenance of remission, which can be low fermentation eating or a medication that helps motility, such as a 5-HT4 agonist or erythromycin. And if symptoms are not good, then you can consider elemental diet or alternative antibiotics. And if recurrence happens, you just follow the same pathway. All right, with that, I'll finish the talk. Thank you so much.
Muchas gracias, Ali, por la presentación que nos ha aclarado el uso de las pruebas de aire expirado. Ahora pasemos al último ponente del bloque, es nuestro mentor de José María y mío, el doctor Satish Rao. Él es el director del Neurogastroenterología en la Universidad de Augusta, en Georgia, y nos va a hablar acerca de las pruebas del funcionamiento anorrectal, como la manometría anorrectal. Adelante, doctor Rao.
Good morning, everybody. And first of all, I'd like to thank Jose. Congratulations on his presidency and for organizing such a beautiful meeting. Enrique, Miguel Valdovinos, and all my dear friends in Mexico and the organizing committee for putting together such a fantastic postgraduate course. So congratulations to you. My task was to talk about anorectal manometry, when, how, and why. My disclosures. Let's see. So I'm going to very briefly talk about anatomy and physiology of the pelvic floor because you really need to master this in order to do a proper anorectal manometry and understand the physiology. And then we'll talk about manometry, its indications, the tools we have, how do we do it, how do we measure and interpret, and what is the clinical utility. Let's see. Neither of them work. Okay, so the rectum is a hollow muscular tube right at the caudal end of the gut, about 12 centimeters long, and it turns itself backward right at the anal opening. So there is a natural barrier which is reinforced with the puborectalis muscle. And there are three important muscles. The internal anal sphincter, which is the caudal-most extension of the circular muscle, involuntary muscle that keeps the anal sphincter closed. The external anal sphincter, which is continuation of the longitudinal muscle, expands and forms the external anal sphincter, which is the voluntary muscle that keeps the sphincter closed whenever we want. Like if you're getting an urge to go right now, but you want to listen to my talk, well, that's the muscle that's going to help you there. And then the puborectalis muscle, which reinforces all of this. And then the rectum is a distensible organ. So you can store stool a long time. An interesting experiment done in Sweden, medical students, a healthy medical student having a daily bowel movement could postpone bowel movement for 3 weeks. That's how much the rectum has the ability to accommodate. So it is an accommodating organ and a reservoir for stool. But the most important area that we have not focused and we had a lot of difficulty is really the neuroanatomy of the inner rectum. In a recent paper that we just published, we really learned a lot over a 3.5-year period about the unique innervation of the inner rectum. And what I mean by that is all we learned in medical school days, and I've taught all my life, is the pudendal nerve is the most important nerve. You can see there coming out of the S2, S3, S4. Indeed it is. But what I think, we need to get this slide. What we have learned is the rectum has very complex innervation and the anal region. There are 5 separate sources of innervation for the anal rectum, and uniquely, the sympathetic and the parasympathetic come together to innervate the rectum and the anal region. And you can see that the blue is the sympathetic trunk coming down, the magenta is the parasympathetic coming down, and the green, which is forming the right inferior hypogastric plexus, is really where both of them are coming together and really innervating this area. But in addition, the same nerves also innervate the bladder and the uterus and so on and so forth. So the anorectal region is extremely complex. And there are 5 sources: the sympathetic, parasympathetic, mixed autonomic, somatic from pudendal nerves, and intercommunicating nerves. Next slide. Okay. Now it's going it has its own mind now. So thank you. So that brings us to anorectal manometry. It is a tool like we've already heard. I mean, John and Prakash and everybody really discussed for the esophagus. We have a similar tool for the anorectal evaluation to measure the pressure, sensory, and the reflex activity of the rectum, and also the dynamics of defecation and continence. So the indications that are generally approved and used is for patients with suspected fecal incontinence, constipation with suspected pelvic floor dysfunction, before and after pouch surgery, facilitated biofeedback training, and particularly in children with suspected Hirschsprung's disease. Then we have other subtle indications, patients with unexplained anorectal pain, prolapse, rectal salt rectal ulcer syndrome, and also very useful for understanding hypo or hypersensitivity of the rectum. In terms of preparation, we really don't need much preparation for the rectum, except that we ask the patients to take an enema the night before, preferably, especially in the constipated folks, because if you do a rectal exam and you find stool, it's hard to do a proper anorectal manometry, as that will blunt rectal sensation, etc. Drugs we try and avoid are opioids, anticholinergics, because these all have effects on rectal function, anal sphincter function. We explain the procedure. One important aspect, because we use a balloon in the rectal manometry probe, there are a lot of folks who have latex allergy. And of course, if you use a latex-free balloon, it is good. But if you're using a latex balloon, because many normative data are based on latex balloons, then check for allergy and do that. A rectal exam is a must. You want to carefully inspect the perianal region. If there is blood or fissure and so on, better not to do anorectal examination at that, not to do anorectal manometry, but bring them back at another time. Also, if the rectal exam reveals a lot of stool, then you want to give them an enema before you do the exam. So this is the lab that we have, and you can see there are a lot of equipment here. In the top left-hand corner is our tower with the high-resolution anorectal manometry system, and that is what we use routinely in our lab for performing anorectal manometry. We have both a 3D catheter system and the regular flexible catheter system. The instrument right next to it is the anal ultrasound system. This is the BK Medical anal ultrasound system, and I use this to assess sphincter defects and anal sphincter morphology and puborectalis morphology. The rest of the two equipment that you see is the neurophysiology system that we use for assessing nerve conduction, and then also for treatment of nerve conduction disorders, including fecal incontinence. The two other pieces are equally important. There's the commode, which I think is very important because that is where we have the patient sit and perform the balloon expulsion test, which is an integral part of anal rectal manometry evaluation. And then the bed with the moon pants, which is a very important pants that we have our patients use because most people feel quite embarrassed about these tests. And if you really have them lying naked, they don't perform very well. So by having an underwear-like garment that really helps to protect the modesty, helps to ensure that you can do a much better quality physiological test. So that is the important thing. Now we have a number of probe systems. We have an air charge probe. We've got the standard high-resolution 12-sensor probe with a balloon. Then we've got the 3D high-definition manometry probe that Enrique and Jose actually helped define the normative values for this, both in Mexico and we did some in Augusta. And then we've got the unisensor probe, which is made by Laborie and so on. And then we have a newer probe system that I'm going to talk a little bit later on. Mostly it is used for biofeedback, but it can also be used for anal rectal manometry. It is a 3-sensor probe system. In terms of protocol, we have the older ARM protocol where we sequentially go from assessing resting pressure for 5 minutes, squeeze for 30 seconds a couple of times, and then push and bear down a couple of times for 30 seconds, and cough. And then we do a combined test of rectal sensation, compliance, and rectal inhibitor reflex assessment. Typically, this takes about 20-25 minutes. And finally, we have the patient sit up on the commode, inflate a 60 cc balloon, have them push and bear down to assess the manometric rectal and pressure changes. They're back on the bed after that. We remove the probe, and then we perform a balloon expulsion test where we place a balloon with 50 ml of water, have them sit up on the commode, and expel this in privacy. Now, the IA, International Anal Rectal Physiology Working Group came up with a slightly modified protocol, a shorter sequencing of events, and that is out there for you all to see. I don't want to go into it in great detail, but it's very similar. Now, the question often asked is it really important that we do all the maneuvers in every patient? And the answer is probably not. But the challenge really is how do we put this into practice? If I'm sitting and doing the test in an incontinent patient, perhaps I'd be a little bit more selective because I don't really need to know if the patient has dyssynergia or not. But in a constipated patient, it's important that I do the push maneuvers. But in reality, most of these tests are being done by our nurses and technicians and so on and so forth. So to try and challenge them to look at the indication for each test and tailor the test becomes very challenging. And therefore, I recommend that we do all of these maneuvers, and then we, as physicians or healthcare providers, interpret the test so that we can really see that all the information we need for a patient is important. What is also important is, although I said in an incontinent patient, I don't really need to see the push maneuver, but what we've recently recognized is about 40% or more of incontinent patients have coexisting dyssynergia. This is what we've called mixed fecal incontinence constipation, MFIC. So you wouldn't pick those features up if you didn't do this maneuver. So it's important to combine all of these maneuvers in every patient. So here I've displayed both the waveform at the bottom half and the topographic form in 2D and 3D manometry. You can see the resting pressure profile. You can see the pressure profile just like the soft manometry. And this is a multi-pressure probe. The lower ones are more in the anal region, and the upper two are sitting in the rectum. Now you contrast that with a patient with a weaker manometry, someone, incontinent patient. So the normal on the left and the right, you can see a patient who has fecal incontinence, much lower resting pressure. You can see the yellow compared to the little green, and then the red, which is the nice strong squeeze, compared to a weaker squeeze that peters out very quickly, a shorter duration squeeze. And that's what you would see in a patient with fecal incontinence. Again, in a 3D, you can see the contrast between a healthy and a weak squeeze. Now, let's moving on to a patient with suspected dyssynergic defecation or constipation. Place a probe in the rectum, one sensor in the rectum, one sensor in the anal canal, and you have a normal subject push and coordinate. You see the waveform, there's a nice rise in rectal pressure, synced with a nice anal relaxation. Also in the topographic form, see the yellow-red, nice rise with the blue, nice relaxation in the anal canal. But in a patient with suspected dyssynergia, you see a variety of forms. The type 1, increase in rectal pressure with a paradoxical increase in anal pressure. Type 2, very poor push with paradoxical anal contraction. Type 3, good push, inadequate relaxation. Type 4, poor push and poor changes in the anal region. All of these are various types of uncoordinated behavior that leads a patient to constipation. Now, there was a paper published by many distinguished colleagues who actually felt that in their study way back in 2015 that the high-resolution manometry system was not providing a diagnostic accuracy, and they were picking up abnormalities of dyssynergia in up to 80% of healthy subjects, whereas you can see the other studies were only picking up about 20% of healthy subjects was dyssynergia pattern, whereas we're picking up in 50% or so in constipated patients. Now, the reason for this outlier study is because of the method that they used to define dyssynergia. They used a criteria called rectoanal pressure gradient, and you can see what they did was, this is a computer-derived, almost like the IRP that the esophageal manometry system provides. So the computer really computes this value and provides a guide to what may be happening in a patient's defecation attempt. Now, just looking at this tracing without really doing any measurements, you can see that the top blue is where atmospheric pressure, the green band in the top is where the patient is pushing. The red at the bottom is where the patient is at rest, and then when the patient is pushing, from red, it is turning to green. In other words, the anal sphincter is relaxing. You don't need any manometry gauge for this. You can clearly see that the anal sphincter is relaxing when the person is pushing. But when you look at the rectoanal gradient, it gives an incorrect value of minus 8.5, which tells you that this patient has dyssynergia, which is wrong, because that is how it computes. Whereas we use a separate measurement where I measure the intrarectal pressure over a 5-second window, 45 millimeters, and then I measure a 5-second window of the reverse relaxation of 30 millimeters, and then if you do an index of 45 divided by 30, you get a normal defecation index of 1.5. So the rectoanal gradient was a wrong measurement, and that's why they got such a high abnormal value in their healthy values. The other important thing is important in anal rectal manometry is the position. Now, nobody poops in the lying position. So we should not be fully assessing manometry in the lying position alone. So here is an example. A healthy subject, a patient with constipation, had them push or bear down. It appears that the patient has abnormal type 1 dyssynergia pattern. Same patient, we sit them up. Now you can see they're nicely relaxing. So body position and rectoanal gradient were the two reasons why that study had such a high value, and these are all important things. Now, in addition to the 4 patterns, we've also described other patterns where it gets a little bit more complicated, but suffice to say that there are very ways in which you can define dyssynergia. So in clinical practice, how do you really define dyssynergia? Well, we use some of the Rome criteria to help guide us. First, your patient must have symptoms of chronic constipation. They fulfill the Rome criteria for chronic constipation. 2 out of 6 symptoms, right? A decreased stool frequency, incomplete evacuation, digital maneuvers, etc. Then second, on the manometry tests like this, they must show a dyssynergia pattern. You saw those 4 patterns, then it really is dyssynergia. But because 20% of healthy subjects also show a dyssynergia pattern, you need one other criteria. And this can be either abnormal balloon expulsion test of more than 1 minute, or retention of stool evidence as with prolonged colonic transit, or abnormal defecography. If any one of these are abnormal, then that gives you the confidence that you're truly dealing with a patient with constipation having dyssynergia, and that is the patient you will now choose to send them for treatment with biofeedback therapy. So that, I think, is very important. Now, what else manometry tells you? Well, manometry is a very good way of identifying various reflexes. Traditionally, we have known of 2 reflexes. One is the rectoanal contractile reflex, where as soon as you distend a balloon in the rectum, the anal sphincter, see that initially the purple and the green rising, that is the external sphincter contraction. This was described way back in 1933 and so on. And then Gowers described the very famous RARE, or the rectoanal inhibitory reflex, where you distend the rectum and the internal anal sphincter nicely relaxes. And this is an enteric-mediated neuronal reflex through nitric oxide and so on and so forth. And this is absent in patients with Hirschsprung's disease. So these 2 reflexes we have known. But more recently, I think, Jose was one of the people who really worked and helped develop this, where we saw something unique, and that is in the middle of the you see the inhibitor reflex in the extreme right-hand corner. There's a little bump in the green and in the blue lines. That little bump is a contractile response happening in the middle of a relaxation response. And this is what we call as a sensory motor reflex response, because it happens when the person feels a desire to defecate. And Jose showed that this particular response was significantly impaired in patients with rectal hyposensitivity. So people who don't feel arrival of stool or don't have a desire to defecate, this response is gone. So this was an important response that we thought was also important, that we called it a sensory motor reflex response. This is the traditional classical rare that you've already seen. The other side of anorectal manometry is to assess rectal sensation and rectal compliance or distensibility of the rectum. So here is a patient, you can see that at much smaller volumes of balloon distension, the patient has reported significant urge to defecate, and at 100 or 120 cc's, the patient is having significant discomfort and pain. So this is an example of rectal hypersensitivity. And finally, here is a patient with impaired compliance, because when we put in 40 cc's of air in the rectal balloon, you can see the intrarectal pressure rising up to 80 to 100. And when we put 70 cc's of air, the patient could not tolerate this also, and then the intrarectal pressure rose up to 120 or 150. So this is a very rigid rectum that is not able to comply. So these are other parameters. In addition to measuring sphincter pressures, we can measure rectal sensation, and we can measure rectal accommodation or reservoir function. This is the simple balloon expulsion test that I already mentioned, where this is a finger cart that we use. We inflate, we place it inside the rectum, 8 centimeters inside the rectum. We distend this with 50 ml of warm water, and then we have the subject sit up on the commode, give them privacy, give them a little stop clock, and then ask them to hit the stop clock when they've expelled it. If they've not expelled it, the nurse will return, and at 5 minutes later, she'll deflate the balloon and remove this. And this is a simple bedside laboratory assessment. Normal value is more than 1 minute, it's abnormal test. And its utility varies in different studies, but approximately 50% of the time it's abnormal. So it's not a perfect test, but really it is a very good test to aid in our ability to diagnose dyssynergic defecation. So what is the overall usefulness of anorectal manometry? You can see in the constipation, we were able to confirm an abnormal manometry pattern, etc., in 75%. We learned new information, such as sensory impairment, and so on. It influenced the treatment in 67%. And even a normal study in 20% was very helpful, because it excluded pelvic floor dysfunction as a cause of their constipation, suggesting it's either a slow transit constipation or something else, and was not helpful in a 14% of patients. Now, very briefly about the London classification. I'm not going to go into great details. This is being revisited. This is very early stages of like the Chicago classification. I think we are now Chicago 4, this is still London 1. So I think there is a lot more to come. I don't want to spend time here, but just to suffice that we're slowly coming there, getting to that area, but hopefully one day we will. What I think is important is when you report anorectal manometry, your report should include a lot of standard information, because you want to really assess anal sphincter rectal pressures, the rare rectal sensory thresholds, the balloon expulsion test, and all the other comments. And then this is the kind of report that we use. And so in a patient with suspected anorectal disorder, you'll take a detailed history, you do a physical and dish rectal examination, you can use a prospective stool diaries or apps, and then appropriately consider mucosal evaluation if needed. Assuming there is no other disease, then you're really suspecting a constipated issue, such as dyssynergic defecation, then manometry, balloon expulsion tests are a must, and you can supplement with defecography and colonic transit. In a fecal incontinent patient, again, manometry, balloon expulsion is good. I supplement with anal ultrasound to get structural information, and neurophysiology testing with TAMS. In a suspected case of rectal prolapse or rectal mucosal intussusception, you want to really rely on other imaging, such as defecography, to really provide more information. And in a patient with anorectal pain, manometry, balloon expulsion, and neurophysiology, I think, are very, very important. Thank you very much for your attention.
You can stay for questions and answers.
Muchas gracias, doctor Rao. Voy a pedir a Walter, Prakash, John, Ali, pasar a una muy breve sesión de preguntas y respuestas. Y bueno, los micrófonos están abiertos. Ronnie y Marcelo, perdón. Los micrófonos están abiertos para quien quiera hacer uso del mismo. Doctor Valdovinos.
Bueno, felicitar a todos los ponentes. Fue una mañana extraordinaria con muchos tips para el correcto uso de las pruebas de motilidad gastrointestinal. Hemos aprendido que los pacientes que usan opioides tienen alteraciones manométricas importantes, y yo quisiera preguntarles si ustedes en su experiencia han visto alteraciones manométricas en pacientes que utilizan agonistas de GLP-1. Es muy frecuente que los pacientes estén utilizando este tipo de fármacos, y quisiera preguntarles si han visto alteraciones motoras esofágicas, alteraciones anorrectales y alteraciones de las pruebas de aliento en pacientes que usan agonistas GLP-1.
I think there's a little bit of data so far in esophageal manometry that shows that there might be some hypomotility, hypocontractility. I'm not sure how clinically significant those findings are for these GLP-1 patients, but there's some report on that. I'm sure more data will come out later.
Oh, okay. So I was trying to figure this out. So it goes on and off. So a question about GLP-1 and breath testing. So there's no question that GLP-1s slow down the small bowel. There is one study that I'm aware of that came out of Mayo Rochester that shows that GLP-1s indeed do increase the chance of positivity on breath testing and also small bowel aspiration. So not surprisingly, they are associated with higher rate of positivity with breath tests. Yeah.
Bueno, sí, me gustaría hacer una pregunta para el doctor Prakash. En relación a la manometría con impedancia, doctor, ¿usted le ve en algún futuro para complemento diagnóstico en obstrucción al flujo de la unión esofagogástrica? Es decir, si tenemos la manometría con impedancia, ¿podríamos prescindir del esofagograma cronometrado, por ejemplo? Nos aportaría tener información sobre el tránsito del bolo. Y una pregunta para el doctor Marcelo Vela sobre rumiación, por ejemplo, cuando utilizamos catéteres de pH con impedancia. Si después de los periodos postprandiales se ha validado algún score para ver si el paciente está con rumiación en la pH impedancia. Gracias.
I guess the question to me is how do you be certain about EGJ outflow obstruction, what kind of testing you can use? I think it starts with the history. So if you're talking about obstruction, you would want to have an obstructive symptom, like dysphagia. So you have to start with the history that suggests obstruction. And if you see evidence of obstruction on more than one modality, so on manometry, if you see features of obstruction on both supine and upright positions, if you see evidence of obstruction on challenge tests like the rapid drink challenge, and then you follow that up with some confirmatory tests, just like FLIP showing an obstructive pattern or a barium showing an obstructive pattern, that gives you some degree of confidence that what you're dealing with is indeed obstructive phenomena. Now, you asked about reflux monitoring in these patients. Yes, indeed, some patients with a manometric pattern of obstruction actually have a reflux-like phenotype. And those patients tend to have reflux-like symptoms, and they will not have conclusive obstruction
on multiple modalities when you are looking for obstruction. So modalities like FLIP will probably show an open esophagogastric junction if there is a pattern of a reflux-like pathophysiology. So I think from a management standpoint, it is most relevant if you can demonstrate an obstructive element that can respond to management. The remainder you're probably going to treat symptomatically. So whenever you have these patients with dysphagia, meal-induced chest pain and regurgitation, and you see intact peristalsis with an obstructive pattern, my suggestion is to look for multiple other modalities and tests that may confirm or be concordant with obstruction before doing anything permanent to the patient.
Sí, en cuanto a la rumiación, típicamente el paciente, si se le hace pH impedancia, en el periodo postprandial va a haber múltiples episodios de reflujo. Sin embargo, lo único que sabe es que el material está refluyendo y no sabe el mecanismo, porque la pH impedancia no puede detectar la presurización en el estómago. Entonces, el estándar de oro es hacer una manometría con una comida y luego hacer un monitoreo postprandial. Se ha intentado tratar de diagnosticar esto con pH impedancia por sí sola, pero por este motivo de no poder documentar la presurización en el estómago, el rendimiento diagnóstico no es muy bueno, y de nuevo el estándar de oro es manometría con impedancia, con comida y monitoreo postprandial.
Gracias.
Gustavo.
Sí, una pregunta para el doctor Faz. En aquellos pacientes con dolor precordial no cardiogénico, ¿tiene algunas reservas para usar el Bravo, ya que esto produce dolor en sí?
So, to understand is that you have a patient with pain?
Non-cardiac chest pain and
do a Bravo in these
yeah.
patients. Yeah, so that's a good question. So I don't see a problem in doing Bravo in patients that present with non-cardiac chest pain and you're concerned that GERD is driving their symptoms. Now, one thing I mentioned in my presentation, remember I had to speak over a very short period of time, 10 minutes, but one of the things we see that when you have patients with esophageal disorders of gut-brain interaction, and maybe one of the patients that you study has functional chest pain, or we see it in patients with functional heartburn, there are studies showing that these patients appear to be much more sensitive to Bravo placement. And as a result, some of these patients may call you and say, I have chest pain, and there were also a few cases where you had to go in and remove the Bravo because the patients did not tolerate it. But overall, in this patient population that you mentioned, patients tolerate it and they do undergo the test.
Thank you.
I think if I can just add a quick comment. I mean, I agree with everything Ronnie said, but what I also find is sometimes this test can help in an indirect way, and that is those patients who experience significant pain with an alpha or a Bravo capsule after the test, they have a hypersensitive esophagus, especially if they have a normal reflux profile, but they complain of a lot of pain. And that's an indirect way of telling that they have a hypersensitive esophagus, which is a cause of their pain. So that is another way that I find that this test can be actually helpful, although you may want to do other tests to confirm it.
John, con FLIP, ¿han hecho algunos estudios para determinar esto? ¿Sensibilidad en pacientes que tienen dolor torácico de presunto origen esofágico?
So FLIP is done while the patient's sleeping, so it's hard to get a provocative response and have them say what they're feeling. It's a little bit uncomfortable to do them unsedated. We've done studies looking at them, but I do think there's probably some information in the reactivity and the thresholds for reactivity. So when you're seeing these patients, you know, we don't really know. I always joke around that we're probably in the era of like Chicago 1.0, 2.0 with FLIP too. It's not, we're in nowhere near where we need to be in terms of to explain everything. But I do think the thresholds where you see contractions occur, the pressure dynamics that are causing those contractions to occur, when do those contractions stop? When do they become quiescent? Like all of those things probably have some relevance and maybe something of a marker of a hypersensitivity or a hypervigilance in the esophagus. But those are definitely studies that you need to get a lot of those studies and then have really good patient-reported outcome measures that you can use because you cannot do it directly because they're asleep, obviously.
Última pregunta, doctora Asensio, por favor.
¿Qué tal? Buenos días, excelente bloque de presentación. Tengo una pregunta para el doctor Vela y es respecto a lo que usted hablaba en la charla de estos pacientes que nos envían para pHmetría con impedancia que muchas veces pues ya han usado de forma crónica IVPs y que en la mayoría de veces pues vemos un reflujo débilmente ácido y no ácido. En cuanto a la métrica o los parámetros de medición para reflujo no ácido, pues en lo poco que revisaba de algunos documentos nos dice que lo normal es que haya menos de un episodio de reflujo no ácido. No sé si tiene alguna otra información para basarnos en eso.
No escuché muy bien, la verdad.
Valores normales de reflujo no ácido, ¿cuándo es relevante el exceso de ellos?
Sí, generalmente más de 80 episodios de reflujo se considera como algo anormal y que en estudios predice que el paciente va a responder bien a una intervención quirúrgica, que es como lo más agresivo, digamos. Y el León 2 pone esos parámetros, más de 80 episodios de reflujo es algo anormal, menos de 40 es algo normal, queda un rango bastante amplio, incierto en medio de estos dos, pero si más de 80 es lo que nos da una buena pauta de que el paciente amerita escalar el tratamiento, ¿no?
Incluyendo no ácidos o débilmente ácidos.
No ácido.
Sí, incluyendo todos los reflujos totales, ¿no? El paciente va a tener mayoritariamente reflujo no ácido y también algo de reflujo ácido porque no se puede suprimir el ácido gástrico las 24 horas, ¿no?
Walter.
I think there were some studies before, I think from Serbeet, that look at some of these normative value, and specifically I think for non-acid they proposed a 30 episode, but I'm not sure how well validated to outcome that is. It's based on healthy volunteers, so it's not clear what that actually means if you just have like 30 something episode non-acid reflux and nothing else, because there'll still be less than 40 total episodes. So there is the cutoff. I'm not sure how relevant clinically that is right now.
No me resta más que agradecer a todos los ponentes por sus magníficas charlas, su tiempo. Muchas gracias y gracias a ustedes por la estancia. Los esperamos puntual a las 10:50 para reanudar el próximo bloque. Gracias.